intoxication. And if there are any questions, feel free to leave in the comment and we will adjust them at the end of the webinar. Now, please allow me to introduce to you our speaker, Dr. Fernando. He currently works at the Intensive Care Unit, Hospital General, Universidad de Castellón, Spain. He also served as a member of Valencia Society of Critical Medicine and Coronary Units, Spanish Society of Critical Medicine and Coronary Units, European Society of Intensive Care Medicine, and Acute Kidney Injury Working Group of SDMI-CYUC. His research interests have included acute renal failure and CRRT, sepsis and septic shock, and oxidative stress, and hemoadsoption therapy. And our Dr. Dalio, medical pathology of the UTE University, professor of medicine, coordinator of postgraduate course in pathology at UCE, medical director for critical pathology at DIAL-NEF, head of pathology department at Adequate Garces Hospital, and also the president of Ecuadorian Society of Pathology. Now, please welcome Dr. Fernando to share his slide and start the first topic. Okay, Dr. Fernando.
Can you see the presentation?
Yes, yes.
Okay. Yes.
Well, thank you very much for the invitation to this webinar. And my topic is hemoabsorption therapy in abdominal sepsis. And just to focus a little bit on the topic, we're going to have a quick look about this subject. Hemoabsorption is one extracorporeal blood purification technique, mainly based on the separation by a solid agent of those unwanted substances that we want to remove from plasma. For a long time, under this attractive premise, it has been seen as a potential weapon to be used in sepsis as an adjuvant therapy under the theoristic point of view that with this therapy we could modulate the immune response to the pathogen. During the last years, because of the COVID pandemics, there was a renewed interest in this therapy, and it has been very used during the COVID years. But we have to take in account that and realize that there's a lot of controversy around this therapy because of the efficacy of these techniques, mainly because they have been published a lot of trials with results that they are not very in favor to the use of these therapies. Perhaps we have to think a bit about why these trials have failed in showing the potential role of this technique. One of the problems is that we can't find two protocols that they are more or less the same, and we can compare when using these devices. Also, we have to notice that there are a lot of different origins of the sepsis that we cannot compare them because of how the immune system responds to every different infection. So perhaps we have to think that in some of these trials, the patient selected for the intervention, perhaps it wasn't the most suitable one for this therapy. HA from cartridges are quite novel devices here in Europe. In Asia, there are a lot of experience with these devices. So when we have the chance to try these devices, we really receive it with curiosity, and we really wanted to try these cartridges. They are described as a non-selective, or they are able to remove by a non-selective way unwanted substances. Mainly, they are used to remove interleukins, and depending on the cartridge, they are able to remove a lot of different substances. And as I said before, there is a lot of experience in China mainly. I bring here two studies from Dr. Zhao, where they show that under controlled circumstances, under randomized control trials, they were able to remove effectively interleukins and other inflammatory mediators. And this was translated in an improvement in hemodynamics, in respiratory system, also with reducing the length of stay and days of mechanical ventilation in certain patients. Here we have another study. Once again, they show that it was able to reduce effectively interleukins and more or less the same results. I would like to notice here one of the oh, sorry, I missed the I missed the slide. No one. Here in these trials, Dr. Zhao presents us about one potential side effect of hemoadsoption that is widely known since hemoadsoption was initiated in last century, and they present us about the potential development of reducing the platelets. In our unit, we recently published a short case series. It's a series that includes five patients, but we wanted to show what happened in our unit with 5 consecutive patients where hemoadsoption was introduced as part of the treatment in patients with abdominal sepsis. All the patients met the criteria or were diagnosed as septic according to the International Sepsis 3 Consensus Conference, and after completing the recommendations of treatment, if the patient met these criteria, all of this, hemoabsorption was initiated. I know that perhaps the doses of vasopressors, they are a bit higher. I know we can talk about this later, but these are the criteria that we use when a patient with abdominal sepsis develops this condition. In our approach, it's not only the presence of sepsis and inflammation. We want to show that with this device, and when an extremely high level of inflammation is proven, that the removal of these inflammatory mediators can help to improve the patient's condition. As I said, we include 5 patients, 3 female and 2 male, all of them with abdominal sepsis origin, and sorry, I apologize. All of them with failure of 2 or more organs under mechanical ventilation, with acute renal failure, and most of them requiring renal replacement therapy. All the treatments were performed with CRRT devices and performed after the cartridge was placed after the filter. In all the cases, the coagulation was driven by with citrate. In our unit, we use both diluted and concentrated citrate. So I bring here just for curiosity if somebody wants to take a look to our protocol, and if you have any question about it, we can talk about this later. And as I said, all the patients were treated with citrate, and here's the treatment schedule. In the first 24 hours, if the patient meet the criteria aforementioned, we start with the first cartridge and a treatment duration of 6 hours. After that, we take a sample to control how was the evolution of IL-6, and the next treatment is performed between 6 and 12 hours after the first cartridge, always guided by the levels of IL-6. If these levels are below 1,000, we stop the treatment. But in all of the patients, we perform at least two treatments. As I said, the treatment duration, the first patient at that time was during COVID pandemics. We had at that time a different protocol, but since then all the patients were treated, as I said, with 2 cartridges, with the schedule that I commented before. About the renal dose, we adjusted that dose according to the urea concentration. So that's why it's so variable, the dose in these patients. What we saw in these patients, that there was an effective reduce of the levels of IL-6, and along with this result, we saw that there was a progressive reduce in norepinephrine dose, and we get even to suspend the vasopressor support in 24 hours. That was really, we think it's of really notice, this finding. Other findings regarding hemodynamics and respiratory, we also saw that there was an improvement in heartbeat. There was an improvement in mean arterial pressure. There was a trend to normalize the lactate levels. Norepinephrine, it was suspended in most of the cases, and there was also an improvement in VO2 ratio. Regarding the renal function, we saw there was an improvement in urine volume, and along with this, of course, there was an improvement in pH levels. As I said before, and as noticed by Dr. Sao in his trials, we saw a dramatic drop in platelets. We cannot rule out that these low levels of platelets, they are not related with the main septic process, or with the CRRT procedure, but it's quite consistent, this reduction in platelets in our patients. As I told before, this was commented by Dr. Zhao in his publications, and I think it's something we should have in mind. Why we choose IL-6? Well, because it's quite easy to monitor at the bedside, and we also has a well-known kinetics. If we catch the patient in the very early hours and we find a huge level of IL-6, and this level of IL-6 is still high with the passage of time, we might hypothesize that this high level of IL-6 is contributing to the organ derangement in this patient. And we think that reducing or helping to the modulation of the immune system by reducing these levels of IL-6, we might prevent the organ damage, and we might improve the actual organ derangement. What we have seen in our population, we identified, since we are using these cartridges, we identified 45 patients with abdominal sepsis. 36 of them, they didn't meet criteria of severity, and in 9 of them we measure IL-6. We think that the difference was made by the levels of IL-6 meeting the rest of the criteria, but the group of hemoperfusion had higher levels of norepinephrine. They had more renal derangement, and in the other group, the recovery was slower. That's true, but they didn't need so much organ support as the other group. As you might know, there was one disease in this group, but it was an old woman with where it was agreed an order of withdrawal. So at the end, this patient died, but the other 3 patients recovered without the effort of this group. So perhaps that's why we set that level as the cutoff when to start hemoperfusion or not. As a key point and key points, and just almost ending, we must realize that there is a current level of evidence that might support the effectiveness of hemoperfusion these days. As I mentioned, it's a highly individualized therapy. Almost every place that uses it has their own protocol. We should be awarded about the adverse events that might be associated with this therapy, and that should warn us that it must be carefully monitored. It has been proven that these devices, at least HA cartridges, provide an effective reduction of excessive cytokines, and possibly helps in the prevention or the reduction of capillary leak syndrome. There also it has been talked about the possible improvement of hemodynamics and the reduced need of vasopressors with these therapies, and the possible prevention of more organ damage when hemoperfusion is added to the therapy. And for example, Dr. Zhao in his studies has shown that this therapy might shorten ICU stay and hospital stay. Just to end, and as a take-home message, I would like to remark that hemoabsorption with HA380 in our unit was associated with an effective reduction in IL-6 and also with clinical improvement. This reduction in IL-6 was followed by a significant reduction in vasopressor doses, an improvement in organ dysfunction. So we can theorize that this therapy might help to prevent organ injury. And the potential benefit of hemoadsoption perhaps should be investigated in carefully designed randomized controlled studies in a specific target population, so we can warrant the optimal timing of initiation, duration of the therapy, and define the exact points to use this therapy. Thank you very much.
Thank you, Dr. Fernando, for sharing your trial with us. Yeah, and now please welcome Dr. Dalio for sharing his slides, and let's move on to the second topic.
Hi, everyone. Let me see if you can.
Yeah, we can see your screen right now.
Yeah.
Yeah.
It's good.
Yeah, crystal clear.
Thanks. Okay. Thanks. Many thanks to Jeffron for the invitation to this symposium. My main objective is to show our experience in the treatment of acute poisoning with extracorporeal therapies, mainly with hemoadsoption. These are my conflict of interest. So we are going to concentrate in a third modality of dialysis, what is absorption. Let me put the point. Okay. And the first one in dialytic modalities to use have is diffusion. Diffusion is the easiest, the most commonly used modality. Principally modify the concentration and permit the diffusion of substances from the blood and across the membrane. The second one is more attractive. I really like this mode, the convection. The convection is based on the movement of the water by pressure and drag. And the third, and finally, the which are interesting in showing today is the absorption. The absorption is based on absorbing toxic substances traveling them in their pot. Let me show you. But it's important understand the terminology and concepts. The absorption is a dialytic modality, but if the extracorporeal technique in which total blood pass through a cartridge with sorbent material, maybe macroadsorbent resin, the name is hemoadsorption. But if only plasma pass through the cartridge with sorbent material, the name is plasma absorption. So it's necessary a plasma separation first. And similar to CPFA in this picture. And you can obtain more information about the standardization of nomenclature in this article. Is the new article in June of this year. And in summary, absorption is a dialytic modality for blood purification. It consists of the passing of blood or plasma through a resin cartridge in which solute is removed. So it's complement convection or diffusion because this technique is only absorption without arrangement of metabolic damage or toxics, maybe in failure, renal, for example, metabolic acidemia or uremia. In this article, in Ecuador, we have had the need to use this modality due to a significant percent of intoxicated patients in critical unit. So, 17% of patients develop AKI in its different stage in our country. And hemoperfusion or hemoadsorption are performed for poisonings in 5%. This is 70 patients in this study. So when start hemoadsorption for acute intoxications is the great questions. The image speaks for itself. And so when you have a situation that threatening life, you need to answer many questions. Maybe is there an antidote? What is the clearance? What is the volume distribution? So, and if you answer is no, no, no for these items, you need to analyze the protein binding. The percent protein binding is important in order to choose the treatment appropriate for this intoxication type. If you have protein binding less of 80%, is important the molecular weight. And you can see the hemoadsorption is the first option or better option in the toxics with a molecular weight to from 12,000 to 50,000. But sorry, let me see. But if the percent protein binding of toxic is between 80 to 95%, the adsorption is the first option. And if the percent protein binding is superior to 95%, the plasma exchange is the option. You need to analyze the protein binding. So in any toxics, in all the patients in your attention, clinical attention, it's important to choose the modality. However, if your first answer was no, or in these items, your answer is yes, 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 the extracorporeal therapy is not indicated. So for our research group, the intoxications are important, but the intoxication are of two types: endogenous type or exogenous type. No? Endogenous type maybe rhabdomyolysis, for example, myoglobin, in liver failure, bilirubins, ammonia, in kidney failure, picresol, leptin, and another disease, myeloma, for example. And exogenous intoxication or drugs, for example, valproic acid, carbamazepine, organophosphorate, paraquat, thiopental, etc. But the only condition they share is inflammation. Inflammation is a condition that is present in two types of intoxication, no? With the cytokines, IL-1, IL-6, etc. For example, this is a patient with rhabdomyolysis, and the rationality for put a a cartridge of hemoadsorption is the objective of remove the inflammatory cytokines and myoglobin. That is the principal toxic in these patients. You can see that it's possible to combine or put in series the hemoadsorption cartridge with hemofilter, for example, pre-filter, and is that not alter the parameters in the machine with CBBH, for example, and the rationality for this application is the molecular sieving. For example, myoglobin has the 17,000 Daltons, and it's possible to remove with cartridge HA330 or a cartridge HA130. No. For example, for rhabdomyolysis, we use from HA330 with good removal of myoglobin and the cleaning CPK levels. Inflammatory, for example, cytokines, inflammatory molecules, in average have 24,000 Daltons. So it's possible to remove with this cartridge type. The rationality is the molecular sieving. CPK is a molecule with 2 units that are usually together and weigh a lot, so it is difficult to remove, but it is serves as a marker of clinical improvement. In this clinical case, I want to show you that hemoadsorption treatment in a patient with thyroid storm. This clinical case is important because this therapy function after the first treatment not work. So the rationality is because the T4 has high binding protein, 70% protein binding, and the hemoadsorption with from cartridge H8 to 30 cartridge demonstrate an excellent and effective treatment option for thyroid storm that threatens the patient's life, especially when first-line drug treatment has failed. This is another clinical case with hemoadsorption alone in cytokine storm, and this one is, let me put the movie, and this one is a clinical case in liver failure case. And you can use a hemoadsorption cartridge together with hemodea filtration online high volume, for example. In this poster, the hemoperfusion experience in SARS-CoV-2, our objective was demonstrate that hemoperfusion is effective to relieve the hyperinflammatory syndrome. But we compared the intermittent hemoadsorption versus continuous hemoadsorption. And you can see that remove the intermittent hemoadsorption was better than continuous hemoadsorption. cytokine storm is not necessary only COVID. COVID is end today, but cytokine storm and hyperinflammatory syndrome was present also, for example, in MAS, macrophage activation syndrome. And in this patient, we decide use the hemoadsorption treatment because the treatment of first line failure in urojective, for example, plasmapheresis, and you can see when we add hemoadsorption to plasmapheresis, the reduce of inflammatory response was better, no? So the patients is with good clinical results and resolve your inflammatory process. In this article, the initial experience with hemoperfusion management of acute pesticide and drug poisoning in Ecuador. Our group of research is the name is Shemine, and the objective was the analysis the time in different intoxication, for example, organophosphate, paraquat, valproic acid, carbamazepine. And at the moment, the starting hemoperfusion in the first 26 hours from the ingestion of the toxic is we demonstrate that this moment is not associated with mortality. So the objective for the analysis is not now the benefit of the treatment. No, now I'm interested in demonstrate in which time is the perfect moment for start hemoperfusion. For example, in this case, the organophosphate intoxication, the objective was to analyze the cost benefit, and it was in favor of hemoadsorption versus classic treatment. Save 3,005%, 3,000 and half in USD, no? American dollars. We always start therapy as soon as hemoadsorption with cartridge or HA230 works similar to van der Waals force and use hydrophobicity and works in order to improve the molecular seed and in electrostatic interaction. The mechanism principal is remove for absorption the toxic of the and remove of the blood circulation. The indication in toxics or in intoxications in general is for pesticides, biotoxin, drug overdose, industrial toxic also. And this is in our work group and show the nephrologists. In our group works in nephrologists and intensivists in ICU, and there are many works related to hemoadsorption, and every time we learn more in daily clinical research. For example, in this paper, you can see that hemoadsorption many times or repeat hemoadsorption is better and more efficient than single hemoadsorption in organophosphate poisoning. And in another paper in relation to acute carbamazepine intoxication, also show that hemoperfusion in the emergency room is better because it's early in remove carbamazepine with results in carbamazepine retention time was shorter than another group. So early hemoadsorption administered directly by emergency doctors was significant relief impairment in conscious the patients, respiratory depressions, and seizures after carbamazepine poisoning. So it's recommended start the treatment early in emergency room and not wait the patient in ICUs. The methodology or the technique the hemoadsorption is easier. Is easier. You need venous houses, dialysis, temporal dialysis catheters, and you need a hemodialysis machine or CRRT machine or hemoadsorption machine only. And you need a blood flow, maybe 100 to 300 flow is adequate in order to pass the blood into the cartridge. The heparin, in order to anticoagulation, the circuit is possible. According of the case, could not be used. The session duration maybe 6 to 8 hours. And it's possible to combine different modalities. For example, hemoadsorption with intermittent hemodialysis or PIRT. And the process is similar. You need put in series cartridge, hemoperfusion cartridge with hemodialysis filter or HDA filter or hemo filter in CBBH or CBBHDF. And the matching is different in relation to the another dialytic modality. The blood flow is different because you can use 200 ml per minute of blood in CRRT, or you can use 300 or 400 ml minute of flax blood in intermittent hemodialysis, heparin according to the case. And in summary, hemoadsorption for acute intoxication is a treatment feasible, easy, safe, effective, manageable, and efficient. Let me show my hemoadsorption group in Ecuador. This is our work group, and it is show that the nephrologist is a good friend of the intensivist. And this group is the extracorporeal therapies of SLAN, Latin American Society of Nephrologists. Is a group that works efficient in the hemoadsorption, CRRT, plasmapheresis, CPFA, etc., etc., etc. Thanks very much for your attention.
Thank you very much, Dr. Dalio. And also thank you for sharing your group with us. Okay, now if there are any questions, you may now type into the comment sections.
Good afternoon. My name is Dr. Alejandra Ramirez Arce. I'm an ICU, a medic from Mexico. And my question is for both of you. We don't work nearby with the nephrologist team in Mexico because they are so charged of patients, and we do the hemodialysis, the slow hemodialysis in our unit. I would like to know more about how, because we have the equipment in the unit, not nephrology. So I would like to know a little bit more about how we can get more information so we can get not the expertise you both have as nephrologists, but me as an ICU doctor to have, we're only just having 2 equipments recently, and we don't know exactly how to use them. And it's very interesting, and I know it can impact in our population of patients, because we have a lot of septic and intoxicated patients. Thank you.
Sorry, Dr. Alejandra, can you repeat your question, please?
I think that Alejandra Ramirez told about of in your hospital, they don't have nephrologists.
We have nephrologists, but they don't work a lot with us, because we have our own hemodialysis machine, a slow hemodialysis machine, and they work apart from us. And I would like to know a little more about this, maybe in private, or you can send me some methods. So because we own the machine, we have the machine in the ICU unit, and it doesn't go out to the hemodialysis system and nephrologists. So we work with it alone.
So you work with intermittent hemodialysis? I can.
Yes.
Yeah. Okay.
Yes. No, the long-term hemodialysis.
Okay. There's no problem to work with these devices combined with any kind of renal replacement therapy. They are. It's a very versatile technique, so you can add it to any modality of renal replacement therapy.
Okay. Okay. I will be maybe in contact with you so we can know more about this. The nephrology team in our hospital is very charged of patients, and they don't work with us in the ICU unit. So we work alone with this kind of new techniques, and it's sometimes difficult for us.
At the beginning, it might seem there's a big deal with these techniques, but once you perform the first treatment, you notice that it's very easy, and the extracorporeal therapist team of the ICU is able to manage with this technique. So it's you will see that it's very easy to implement this technique in your unit. Here in Spain, in my unit, nephrologists only come to those patients that they are in chronic dialysis and they are about to leave the ICU as a previous step to being sent to the ward. So here we manage all the patients with need of renal replacement therapy, and when we perform hemoperfusion, we have one specialized team with this. Obviously, you need sessions of learning how to manage this, but it's quite easy and fast to implement this kind of devices and include it in the treatment of your patients.
Alejandra,
okay,
I'm sending my address email in the chat of this symposium, and you can contact me anytime. And if you is necessary in Spanish, is better. Okay.
Thank you.
Yo estoy en Ecuador. I'm from Ecuador, Quito, Ecuador.
Okay. Sí, doctor.
Sí.
Thank you a lot. We work, trabajamos con otros tipos de filtros. Es la primera vez, apenas nos acaban de llevar estos filtros. Entonces, muchísimas gracias. Me pongo en contacto con usted.
Sí. Okay. It's the same.
Muchas gracias.
It's the same cartridge. See, the macroabsorbent resin is works similar to another resin, but it's important now that the Jafron cartridge has a different molecular sieving, so is I have different options for different molecular treatment. For example, HA230 is specifically for toxins and poisonings, for example, and HA330 is more specific for inflammatory molecules. For example, in sepsis, Fernando works and show a great work about this. And HA130 is used. You can use in hemodialysis chronic in patients with chronic kidney disease. And there are cartridges also for remove bilirubin in failure in liver failure specifically.
Yeah,
thank you.
That's why I referred. We work with Oxiris. We work with ST100, ST150, but it's a new thing I would like to know, because what about you were talking about, you were both talking about, it could impact in our population, because we have a lot of this kind of patient, and it amazed me that it works in thyrotoxic intoxication, and we have a lot. We have recently too, and we didn't have this kind of technology, and it really worked out for us. So I would like to know more. Thank you both.
Thank you, Dr. Fernando and Dr. Dalio, for your comprehensive response. And I see there's also a question in the comments regarding to the low PLT. Can you see it?
Yes, at least in our patients, not only in this series, in other septic patients, we have noticed this low level of platelets. But as they ask, no patient required platelet transfusion. We didn't register any adverse event apart from the reduction of the platelets. We didn't had any adverse event like bleeding or something like that. And about 24 hours ending the treatment, platelets recover in all the cases. So I think it's something that it should be globally investigated.
In my experience, low platelet and hemoadsorption treatment is not a problem. It's not necessary transfusions. I don't see bleeding. It's not a problem. The plaquetopenia.
Okay, thank you. And also there's a last question about, so do you apply the therapy for any sepsis patient, or do you have a selection criteria?
Yes, we have a selection criteria. We applied this therapy when after receiving the correct treatment, and we ensure that there's a correct volume load and the correct antibiotics, the infection source has been drained, and when we have covered all the sepsis bundles, if the patient remains under a refractory shock without response to the treatment and the need of high doses of pressors, we start with hemoabsorption in case of or in presence of 2 or more organ failure with a SOFA score above 9 points, blood lactate above 2 millimoles per liter, procalcitonin over 10, CRP over 100, and IL-6 over 2000 picograms per milliliter. I hope this might answer the question. And we continue with the therapy until the vasopressors requirements are reduced at least by 50%, and the levels of IL-6 are under 1000 picograms per milliliter. This is our approach and our protocol to use this therapy.
Thank you. So, Dr. Dalio, you got any comments on this question?
No, I don't have any experience in sepsis.
Okay.
Because I'm centered in intoxications, but I read any comments and publications about this. But my experience was in COVID, and with the cytokine storm. Today the name is hyperinflammatory syndrome, and you can show in my presentation the comparison inclusive between Jaffron intermittent hemoadsorption versus cytosorb continuous hemoadsorption, and the remove of the cytokines was adequate, and the mortality was better with intermittent hemoabsorption with Jaffron versus continuous hemoabsorption. But it's a experience into the pandemic. But in sepsis, I think that we are waiting for the results of the Tigris study. Dr. Kellum is works in this study in USA, and I think that on the December maybe we can see the results of this study, and this study maybe open the mind of the people in relation of the results in relation to the sepsis.
Thank you, Dr.
indication.
Lan. Okay, thank you, Dr. Dalio, and thank you, Dr. Fernando, for your sharings of your cases. And sorry about the 15 minutes late of this webinar. Yeah, and I hope everyone's getting what they want. And if there's any further questions, you may contact us or Dr. Fernando or Dr. Dalio. Yeah, and our webinars may call it an end here. Thank you for attending.
Thank you very much for the organization, and thank you for all.
Thank you
for the attendance. Thank you.
Have a good day.
Thanks a lot. Thanks a lot. It's a great pleasure compared with Jaffron in this symposium.
Keep in touch.
Hello. Hello. Hi.
Hi. Hello.
Hi.
How are you?
Hello.
Hello, this is Parisa, behalf of United Arab Meteorite Company in Oman.
Hello, Parisa.
Hello, doctor. How are you?
Hello.
Nice to meet you. Thank you. Fine. Actually, we started a clinical trial study about hemoperfusion cartridge in hemodialysis patient in Oman.
Yes.
Actually, at the Noam in hemodialysis center, I can to show you the level of PTH to my colleague. 12 of July, the level of PTH 248. After that, 9 of 8, the level of PTH 106. Actually, after 9 session,
Hello, Felicia. Your internet, your connection is not good. Hi. Felicia?
about in hemodialysis patient, and we compared result of yes, actually we got RD in one. Do you have my hearing?
Sorry, Parisa, I think your connection is not working properly, and we couldn't hear what you said in the last 15 seconds.
Excuse me, I have a problem in data.
Yeah.
Yeah.
So can you repeat what you said?
We hope after the finished clinical of trial, we can to publish an article in Oman, and MOH of Oman support hemoperfusion cartridge for hemodialysis patient. Thank you.
Okay. Thank you, Parisa.
Thank you, doctor. Thank you for supporting. Nice to meet you.
Okay, thank you, doctor. And
thank you.
We may call an end here right now. Okay, so see you, Dr. Fernando.
See you. Thank you very much.
See you.
Keep in touch.
See you.
Yeah, see you.